All right, let's do one more. I'll let you choose one more from those four.
Shall we do post-operative oliguria?
All right. So you have a 48-year-old female patient, persistently hypotensive following a total hip replacement or a Hartmann procedure. Sometimes it comes as Hartmann procedure. She was transferred to the ward at 3 p.m. She was hypotensive, tachycardic, with a blood pressure of 70/30. And you will be given a fluid chart as well that will show you how much fluid the patient was given. And this patient was given 2 bolus of 250 ml over 15 minutes with a very small improvement initially. You will be asked to interpret the fluid chart. So what are we actually looking at when trying to interpret it?
So on this fluid chart, I can see that the patient is had 2 fluid challenges and nothing in between. They've had a small improvement, however, are still hypotensive and tachycardic. My main concern here is that the patient has post-operative oliguria.
And is the amount of fluid given adequate?
No, the amount of fluid here is not adequate.
And how would you manage this case?
So given the fact that the patient has had previous fluid challenges, they've had 2 previous fluid challenges, I'd like to manage this patient according to CRISP protocol. I want to do a full history and examination of the patient and review the drug chart that I've been given and medication chart. I would like to give a additional fluid challenge and monitor the response. I'd give a 250 ml bolus over 15 minutes. And I'd want to identify, this would be diagnostic, I'd want to identify if this is hypovolemic. If they have response to this, then I would start fluid resuscitation. And if there was no improvement, I'd like to repeat the fluid challenge up to 4 times, which would equate to 1 litre.
What formula do you use for fluid challenge?
So the formula used for fluid challenge is 20 milligram per kg over 30 minutes.
The patient is on 2-hour monitoring. Is that adequate?
No, the patient should be managed hourly.
And who would you notify and when?
So I would notify my consultant on call and the ITU consultant as well. I would notify them if the patient was unresponsive to the 4 fluid challenges, as I can give up to 4 according to NICE guidelines. This is important as the patient would need to be monitored either with a pulmonary arterial catheter to monitor their cardiac output, and this typically can be done in an ITU setting.
And how would you calculate the blood pressure?
So blood pressure is calculated, blood pressure equates to cardiac output times heart rate, and cardiac output is calculated with heart rate times systemic stroke volume, So blood pressure is calculated cardiac output times systemic vascular resistance, and cardiac output is calculated by heart rate times stroke volume.
According to this equation, how would you increase the blood pressure?
So cardiac output can be increased by inotropic support and giving IV fluids, and vasopressor agents can increase systemic vascular resistance.
Right. What is the hormonal response to surgery?
So the hormonal response to surgery is based upon a stress response. So because of this, we have increase in cortisol secretion. This is from the zona fasciculata in the adrenal gland. We also have an increase in adrenaline and noradrenaline, and we'd have an increase in cytokine secretion. We have a decrease in thyroid hormone stimulation, so decrease in TSH and T3 and T4.
What are the mechanisms by which the kidneys increase the osmolarity in the renal medulla?
So this is by the theory of the countercurrent multiplier. So here you have the countercurrent multiplier, which is based upon medullary hypertonicity. We have reabsorption of sodium chloride in the thick ascending loop of Henle. This is because it's impermeable to water, but permeable to sodium chloride. And therefore you have an inflow of sodium chloride into the PCT and ascending loop of Henle. You have fluid leaving the PCT, which is isotonic, and you have an efflux of sodium chloride from the ascending loop of Henle. And also because of the vasa recta, you have a flux of water from the collecting duct tubules.
What is the mechanism of the ADH?
So the mechanism of action of ADH is based upon the V1 and V2 receptor. The V1 receptor would cause vasoconstriction and therefore increase the risk for vascular resistance. And the V2 receptor is for water reabsorption in the renal, predominantly the collecting duct and also the distal convoluted tubule by the increased secretion of aquaporin 2. It's stored in the hypothalamus and secreted from the posterior pituitary gland in response to hypovolemia.
All right. We talked about RAS in the previous lecture. It's the same thing here, basically. So it leads to vasoconstriction to veins, arterioles, and salt and water retention by ADH and aldosterone. Not sure if there's anything to mention here. Corrected yourself in the blood pressure. I think I need to rephrase the question because that doesn't make sense, to be honest.
The equation?
It's asking about the blood pressure equation and the significance of that. Hormonal response, cortisol, adrenaline, and cytokines. And just mention that this is the stress response. Surgery is stress, which you did. This is obviously, I might need to rewrite this in a better way, but you've made a good summary of it. I think that's it. There's nothing really to add. For interpreting your flow chart, I think the key points to mention that you're looking at in the flow chart, first of all, you're looking at the patient blood pressure and the intake and the output. So the output is very important.
Because it's if they're in a negative balance or positive balance.
Correct. So the output needs to be mentioned as well, right? So what's the urinary output, whether it's being calculated or not, whether the patient have a urinary catheter, and all these questions. Okay.
Sometimes I think in the STEM they ask about cardiac output and how that's measured. So lithium dilution, cardiac output monitoring, and pulse control analysis, and central line and transesophageal Doppler, I think. But those are just specifics, aren't they? We had this STEM in teaching today. There's STEM stuff that I'd obviously not read about, but had to read up about.
I wasn't aware of that, but can be added as well. I think overall, well done.